Dakshaben, good evening. Late to good evening.
Dakshaben બરોડામાં છે સતીશ.
એવું છે? Oh,
સતીશ દક્ષાબેન came before 10 days.
oh. Dakshan, તમે mute છો Dakshaben, તમે please unmute. That is good to know.
Yeah.
Like, તો હવે મતલબ કોન્ફરન્સ અટેન્ડ કરીને જશે BMC?
Yeah, they are here for 4 months.
Oh, that's a very good news. Dakshan, unmute તમારું mute છે. So we wait for a couple of more minutes, let people join, then we start. We are
Good
already
morning,
live.
Satish bhai.
Good morning. So there is an epilepsy week or what? Smriti, you are referring?
Yeah, ma'am. Yeah, sir. So this is a November month is basically a National Epilepsy Awareness Month.
Okay.
Yes, sir. So I think various activities done by the even the doctors, as well as there are some pharma people also, they for the social awareness also, they prepare some kind of social, they do some social activity and prepare the video on the social media.
Yeah, it helps. It helps the parents to understand the issue better.
And febrile seizure is like a very common thing to occur, but it is still devastating for the parents in the simultaneously.
Very true.
Can you hear now, Dr. Pandya?
Yes,
now you can hear.
Yeah.
You can hear. કેમ છો દક્ષા?
Also એકદમ fine.
જગદીશભાઈ કીધું તમે અહીંયા જ છો હમણાં એટલે મળીશું.
હમણાં જ આવ્યા, last week આવ્યા. Yeah.
હું કલકત્તા છું, રેસ્પિકોન અટેન્ડ કરવા આવ્યો છું.
Oh, okay. Good.
Yesterday we had a very wonderful workshop on sleep whole day. Very heavyweight faculties, Mahesh Babu, then Suresh from Australia.
Okay.
They are very big names in the sleep medicine in pediatrics.
Okay.
Such a pleasure to interact with them.
Yeah.
I'll present a synopsis of sleep workshop.
In Saturday evening. Okay, good.
So many things which I learned, which I think I can implement in my day-to-day practice. We don't do PSG so often, but that is polysomnography. But then there are a lot of other things which we can do to our patients as far as sleep medicine is concerned. So many issues.
So also narcolepsies and parasomnias, everything must be there.
Yeah, everything was discussed. So that was a little bit part of it, parasomnia. A lot of things about sleep hygiene in adolescent infants.
Okay.
And of course, disorders, hypersomnolence. OSA was not discussed much about it. And then we had a sleep lab visit where we actually saw how they are doing it, how they are interpreting it, what are the things that need to be done.
Okay.
So it was a wonderful experience, very well arranged. They arranged it at Manipal Hospital in Kolkata.
Okay.
So I think we can start now. Yes. So good morning, friends. Welcome back to Saturday Club morning meeting. Today we have our guest speaker, Dr. Smriti Patel. We have already heard her before as a guest speaker in Saturday Club of Baroda. She's a pediatric neurologist from Vadodara. She did her MD Pediatrics in 2016 from Baroda Medical College. She worked as assistant professor at Sumandip Medical College and Hospital 2017 and 18. And then she had her fellowship in pediatric neurology from very reputed Christian Medical College, Vellore, in the year 1820. And since then, she has been practicing here in Vadodara. She is a consultant pediatric neurologist attached to KJP Children Hospital, a very reputed hospital in Vadodara. And she has her own clinic, that is Growing Brain Child Neurology Center. And her areas of special interest are refractory epilepsy, pediatric stroke, neuroimmunology, movement disorder, and rare diseases, especially DMD awareness activity. And she has been doing a lot of awareness activity. And just now she told us that this is an awareness week for epilepsy. So we are happy to invite her to talk about an update on management of febrile seizures in childhood, a very common problem in pediatric practice and very scary also for the parents. So Smruti, thank you for joining us, and it's over to you now. You can speak for about 40-45 minutes, and Dr.
Okay.
Jagdish will conduct the final session of question answer, because I will be leaving for conference in a while.
Sure,
So
sir.
thank
Sure,
you very
sir.
much for joining us. Over to you, Dr. Smruti.
Yeah, thank you. Thank you very much, sir, for giving me this opportunity. I just said 2-3 days back to sir that I want to present a seminar on febrile seizure, as the November is the epilepsy awareness month. So sir immediately said, like, do you want to present on this Saturday? I said, okay, sir. Yeah, I think I'll do it.
That's not so. It was a good opportunity.
Yeah, sir. So I'll just start sharing the screen.
Yes.
Is it visible, sir?
Yes. Yes.
Okay. Yeah. So, as I said, like febrile seizures are very common in childhood, and it is the most common seizures, like in less than 5 years, where the child presents with the fever and seizures. So there are so many things. It's so common that we know everything. Like sometimes we feel that we know everything about the febrile seizures, but in the real scenario, when the patient comes, sometimes we feel that it could be a febrile seizure, or it is not febrile seizure or something beyond. So today in my talk, I'm going to, discuss such kind of scenario. So in my presentation, I'm just narrating these presentations where, in a different way, the child can present with fever and seizures. And at the end of my talk, we are going to discuss each case. So I'm narrating the situation. This is a case 1 where the 14-month-old boy who presented with generalized seizures on day 1 of fever, developmentally normal, remains alert, and there were no neurological deficits, no signs of meningeal irritation. These are the most common scenario we are facing. The second scenario where the 30-month-old girl with a simple febrile seizure, she already had 3 episodes in past 6 months, presented to the emergency with the active seizures and fever. And here the parents are uneducated, the healthcare facilities very poor. Accessibility is very poor. So now what we will do in this scenario? Case 3. Here there is a 7-month-old girl who was incompletely immunized, presented to the emergency with a history of brief GTCS along with the fever at home. Case 4. This is 2-year-old girl with the focal seizures lasting for 12 minutes on day 1 of fever. And here the family history of febrile seizure is there, but there's no neurological deficit. So on and off, we are facing such kind of case scenario. This is a little something all scenario where also the child can present with the fever and seizure. This is a 4-year-old boy with fever for 2 weeks with headache and vomiting. And on 2nd week of fever had GTCS, and on examination, he had meningeal irritations. This is the case 6 scenario where the 8-year-old boy history of febrile seizures in past, now presented as fever as well as afebrile seizures, but multiple seizure symptomology. So this is something different than the febrile seizure. This is case 7. Here the 9-year-old girl, history of complex partial seizures in past, recurrent episode of focal motor seizures, which is in temporal lobe epileptic prototype. And this is my last case. Here the 6-year-old girl with a history of fever 10 days back came with a history of refractory status in emergency and even in PIC on multiple AEDs. So these are the different scenarios. Of course, at the end of my talk, even the audience can participate in this and they'll be able to answer. So we'll have two-way communication in this case scenario. I'll start my introduction for the febrile seizure. So what is febrile seizure? So it is defined by American Academy of Pediatrics or Indian Academy of Pediatrics as fever with seizures. So how much fever? At least 100.4 degree Fahrenheit or 38 degrees Celsius and associated with seizures. And those children, they do not have any evidence of intracranial cause, like, something kind of infection, trauma, or underlying epilepsy, or any metabolic cause like electrolyte imbalance or hypoglycemia. And there is one more criteria. This child, they should not have any past history of afebrile seizures. And the age bar is 6 months to 60 months, that is 5 years. So these are the criteria for having typical febrile seizures. But there is something different in the definition, which is defined by ILE, that is International League Against the Epilepsy. They define the age bar is older than 1 month, so 1 to 60 months. And the NIH, which is National Institute of Health, they define the age bar is 3 months to 5 years, but the rest of the criteria are same. So now, what is simple febrile seizures and what is complex febrile seizures? So to define the simple and complex is very important, because the risk of future epilepsy is different in simple and in the complex. That's why it's very important clinically to differentiate between simple and complex, and as a management perspective also, which we are discussing later. So what is simple? If there is a single episode in a day, if it is a generalized episode and the duration is less than 15 minutes, in this criteria, the seizure calls a simple febrile seizures. If the seizures are focal, and if it's too prolonged, like more than 15 minutes, still reaching to the hospital, the child is seizing until unless he got the IV anticonvulsant. So that is a feature of complex febrile seizures. Or the seizures reoccurs 2 times, 3 times, 4 times, multiple times in a hospital settings, which is also called a complex febrile seizures. So there are different cutoffs are also like, the 15 minutes or 10 minutes, but they have taken a threshold of 10 minutes. Why? So if the seizure is persisting more than 10 minutes, it's very, low chances that the seizures gets resolved by itself. The child will require anticonvulsant to stop the seizures. So and more than 10 minutes, there is high chance that the brain can injure. That's why, in our various definitions, now they have taken a cutoff of 10 minutes also. And what is febrile status? If the seizures the duration is more than 30 minutes or multiple episodes like shorter serial seizures without gaining consciousness in between. That is also called febrile status. This is defined by the FAPSTAT study, which is for the febrile seizures. There are some different definitions for complex also, other than what I've mentioned. Other than that, if there is a prolonged postictal, usually the postictal is for a few minutes to at least less than an hour. If it is more than an hour, so the child is not recovering to the baseline state even within an hour, so that is a prolonged postictal. Or the child is developing Todd's paralysis, that is weakness where the seizures been developed. Like if it is something right focal, for the few minutes, the parents tell that the child got conscious, but he's not able to lift the right upper limb. That is called the Todd's paralysis. That is a postictal phenomenon. Or if there is a requirement of the anticonvulsant drug to stop the seizures. These are also criteria for the complex febrile seizures. Now, if we see the data for the epidemiology, usually it is 2 to 5% of the normal children, it is common. And it is more used to happen in the Asian population, that is 5 to 10%, and Japanese children. The peak age of onset is around 18 months. So the peak age or maximum age where the child present with the febrile seizure is around 1.5 years. Why it is? Maybe it is some kind of like some kind of immune factors, or that is the age where the child is exposed to the environment and they can have chances to get the multiple viral infections. So multiple reasons why they develop around 1 year. If we see the male to female ratio, it is higher in the boys than the girls. It is more common in the lower socioeconomic strata, maybe because of, getting chance to have an infection is more common. And majority of febrile seizures occurs in the winter month, because these are the months where, they're exposed to the many URTI and influenza or parainfluenza groups of infections. So, so what, like when the child gets fever, like how many hours of fever the child have a propensity to get the seizures? So there are 3 criteria, like 21% of the children within an hour of onset of fever, they'll get the seizure. While most of the patients, almost more than 50% of the patients get the seizures within 24 hours. while only a few, like 22% of the patients get the seizures more than 24 hours, but within 72. So maximum age limit is around 3 days, that is 72 hours. So febrile seizures are like age-dependent response to the immature brain to the fever. Why it happened? Like, you know, all the children does not get the febrile seizures, though they have all on and off febrile illness. Because, you know, till 5 years, the child's brain is growing, like all synaptogenesis process are happening. And during synaptogenesis, all the neurons are in the little excited stage because there is more of excitatory neurotransmitter gets released. So they have propensity to get, you know, more excited during the high grade fever. But there are certain genetic predisposition also. So that because of that, you know, very few children develop the febrile seizures that we see, like what are the probable etiological factor. If you see, there is a 33%, that is 1/3 of the patients, they can have positive family history. And the risk is increasing when the sibling has febrile seizures or the parents have history of febrile seizures. So if there is a history of febrile seizures in sibling, there is a 20% of the chance that the index child can have seizures. Well, if there is history in the either of parents, the risk increases to the 33%. And there is more chance in twins also. So it is higher in monozygotic than the dizygotic twins. So these are the risk factors for the febrile seizures. So it could be genetic and it could be environmental also. So in genetic, there are various genes, especially SCN1A, 1B and GABARG1 genes are associated. While in the viral infection, the most common are the influenza, parainfluenza, and the HHV6, which is Roseola infantile. There are some other viral infections which are associated with pharyngitis or otitis. They can also associated with febrile seizures. And of course, during the COVID, the human coronavirus HKU1 also associated with febrile seizures. This HHV6B, which is, you know, very common for the febrile status epilepticus. Nowadays, there are, you know, like kind of many cases are coming up with the meningoencephalitis associated with HHV6 and, you know, febrile seizures. The vaccination, they have similar role. It's not like all the patients who receive the vaccines, they get the febrile seizures. In the natal or perinatal risk factors, of course, the prematurity and if the child is IUGR or having the prolonged night to stay, they are more prone to get the febrile seizures. And of course, in nutritional, nowadays, there are so many studies are going on for the vitamin D deficiency and iron deficiency, anemia. They are more predisposed to get the febrile seizures. So these are the risk factors, as I said, like male gender, family history, high temperature, lower socioeconomic strata, then season, neurodevelopmental delay, daycare attendance, and of course, you know, allergies and immune factors are also associated with febrile seizures. Now, when the patient comes with the history of any paroxysm, like, you know, the child had some kind of abnormal movement when he started having fever, this could be, you know, differential diagnosis unless the parents are very sure or if they have a video to label them as a seizures. You know, sometimes we can misdiagnose with the shaking or like rigors to have a febrile seizures, because when the fever rises in the viral fever, it rapidly rises. When the fever rapidly rises, they can have rigors or shivering, which can, you know, mimic like a febrile seizures. And sometimes because of the high temperature, they can go in the delirium state, which can, you know, mimic a post-ictal type of state. And of course, you know, not beyond febrile seizures could be like a CNS infection is the preliminary symptoms to have seizures. And of course, in that age, breath holding spells are also common. Sometimes that can also mimic the febrile seizures. And it could be like a febrile seizure it could be initial symptoms of evolving epilepsy syndrome, like, you know, SCN1A epilepsy, JEPS plus or Dravet epilepsy. So now how you will approach the child and what are the history, what is important clinical points and examination points for the evaluation of the child who is presenting with the febrile seizures. So of course, age. You know, if it is a beyond 5 years, definitely it's not the febrile seizure. So typical age. And even below 6 months also, there should be a high suspicions for the CNS infection. So age is very important. Of course, the family history of febrile seizures as well as epilepsy, because that defines your risk factors for having recurrence of febrile seizures and epilepsy in future. Then history of developmental delay, then duration between the beginning of the fever and seizures. Why it is important, we are going to talk later. Then complexity, duration of the postictal phase. As I said, like if it is a prolonged postictal phase, it is a red flag signs for the febrile seizures. Like it could be some kind of CNS infection or some other electrolyte or metabolic imbalance. So then, of course, in examination, we need to see is that the child is having papilloedema, if he's altered sensorium, is there any focal deficit or any meningeal irritation signs or petechiae or purpura. So now we are going to see how we are going to manage a child who's presenting with the febrile seizures, how we are going to evaluate. So, when we were going to do the EEG, when we are going to do MRI or CT scan, is it indicated? Is the CSF or, lumbar puncture is indicated or not? So, we are going to have this guideline based on the evidence. So, all based on the RCTs and observational studies and the case control trial. So whether it's a level A, B, or C, what is the evidence of the quality? So these are like different statements I'm going to tell you. So regarding the lumbar puncture, so when it is indicated, so lumbar puncture should be performed in any child who present with the seizures and fever and who has signs of CNS infections, like they have meningeal signs, or in the examination they are very irritable. Maybe in the young child you won't get any meningeal irritation signs, but they'll have excessive irritability or some kind of focal deficits. In those cases, that is a level B evidence that we should go for CSF, and the benefits are more in doing the CSF than the harm. So it is strongly recommended. In any infant between 6 to 12 months who present with a fever and seizure, a lumbar puncture is an option, especially when they have not received the vaccinations or they are partially immunized for Hib and pneumococcal pneumonia immunizations, or status is unknown. In those cases, definitely we need to go for CSF, and here the evidence is level D. So preponderance of benefit is more than the over the harm. So this is an opinion. So case to case basis we can decide upon looking at the clinical picture, and we can have a CSF. A lumbar puncture is an option in a child who present with the seizures and fever who are pre-treated with the antibiotics, because sometimes giving an antibiotic can mask the symptoms of infections. So if something odd into the history that the child is having continued to have fever, and which is, like we are not able to identify the focus of fever, and child used to have clusters of seizures beyond 72 hours, but not showing irritability, in those definitely, to rule out the infections, we have to go for CSF, because, sometimes giving antibiotic can mask the symptoms of meningitis in the young age. The EEG is not be performed in the evaluation of neurologically healthy child, especially with the simple febrile seizures. It is not indicated, and it is strongly recommended, and it is having level B evidence. So EEG is not routinely performed for the febrile seizures, typical febrile seizures. But if it is, febrile status or any complexity like focal seizures, prolonged seizures, there is a seizures with very query having a fever or having the developmental delay or, some kind of autism. So in those cases, definitely we should perform the EEG. The following tests should not be performed routinely in the sole purpose for the identify the cause of typical simple febrile seizures, like all this electrolyte, calcium, sugar, if it is a typical simple febrile seizures. And even the neuroimaging should not be performed in routine evaluation of simple febrile seizures, and there is level B evidence. So again, this is a guideline where the child presents with the simple febrile seizures, no further evaluations, only and only educations and emotional support to the family is required. But if it is a complex febrile seizures, then we need to see if there is an abnormal development or assessment in the CNS examination, or having a complex feature, family history of epilepsy, then we should do the further assessment in terms of EEG. If seizures are focal and prolonged, we have to do the MRI with or without contrast. And we need to consider the CSF if the child is less than 12 months, or if the age is more than 1 year and showing the signs of CNS infection. So again, the use of EEG and its timing. So again, so if in complex febrile seizures, you want to perform an EEG, what is the timing? Like when we have to perform. So the Cochrane says there is no such guidelines are available till, they have whatever the possible, they have sources they have examined. But in that, the use of EEG and its timing after the complex febrile seizure is not known. So well-designed RCTs should be required to label the timing. But as per the practically, if we see, as soon as possible, whenever the patients have seizures and if it is focal, we try to identify the focus. We need to perform EEG as soon as possible. So now we are going to discuss about the regarding the recurrence of the febrile seizures in future and epilepsy, because always the patients, whenever the patient comes with the febrile seizures, the next questions for the parents is whether my child get the seizures in future, whether my child is going to have epilepsy in future, whether my child requires anti-epileptic in a long time. Is there any is there my child is having any developmental deficits or intellectual, he's prone to develop the intellectual disability in future? So all those things we are going to discuss now. So so there are different risk factors for febrile seizures, and there are certain risk factors for epilepsy in future. So what are the risk factor, definite risk factor for having febrile seizures? So first is if the family history, either in siblings or either in the parents or in the cousins, there is a family history of febrile seizures. And if the age is less than 18 months, they can have propensity to get the febrile seizures till the 5 year of age. Third risk factor is height of peak temperature. Now, we need to see, that is the third questions we need to ask to the parents. Have you checked the temperature when your child is seizing? What is the temperature? Because that height of the peak of temperature defines your, recurrence of the febrile seizures. So if there is a child is getting the seizures at around 101 degree Fahrenheit, there is almost 42% risk that next 1 year he is going to get the seizures. If the peak temperature is around 102 or 103, the risk would be around 15% that the child will get the seizures. And if the fever peak temperature is around 104 to 105, the risk would be less than 10%. So higher the peak, lesser the chance that the child can get the seizures in future. So that is an inverse relation of height of the peak temperature and getting seizures. And the fourth definite risk factor for having febrile seizures is duration of the fever. Like whether the child is getting seizures within 1 hour of onset of fever, within 24 hours or beyond 24 hours. So we have discussed in the previous slide. The shorter the duration, higher the risk that the child can get the febrile seizures. Now, what is the possible risk factor for febrile seizures? Of course, family history of epilepsy. And what are not the risk factor? Gender, ethnicity, complexity, neurodevelopmental delay. Those are not risk factor that the child is going to develop the febrile seizures. Now we have to see how many risk factors are there. If there is no risk factor, maybe 12% chance that the child can get the seizures in next year. If there is a 1, then the chance would be 25 to 50. If there are 2, then it is almost 50 to 60. And if it is more than 3, it is 73 to 100% chance that the child can get the recurrence of the febrile seizures. Now, what are the risk factors for the epilepsy? So NDD, complexity, family history of epilepsy, then of course duration of fever also. They can have, the future risk of epilepsy. And here all again the rest of the things like family history of febrile seizures, age, height of the peak temperature, those are not the risk factor for the epilepsy. Now, the risk of epilepsy is different. Like if we see the normal population, it is 0.5 to 1% for getting epilepsy in future without anything, like without any history. The simple febrile seizures, the risk increases to only a 1%. While in the rest of the other factors, like if it is a recurrent febrile seizures, the risk is 4%. If the duration is more than 15 minutes, the risk increases to 6%. If the fever is within 1 hour of fever, within 1 hour of fever, the child is getting seizure, the risk increases to 11%. And if the family history is having epilepsy, then risk increases to 18%. And the focal seizures and NDD, again, it risks to almost 30 to 33%. So these are all different study and logistic regressions which analyze the risk factor for having febrile seizures recurrence. You can see that age at the first seizure, temperature, duration of the fever, and the family history of febrile seizures, they have the p-value is less than 0.05. So which is significant. While the Xander and the family history of epilepsy, the p-value is more than 0.05. So it is 0.8 and 0.82, so which is not significant. Now, in the what are the responsibility of the primary treating physicians when the patient comes to the emergency with the febrile seizures? So, of course, first is to give the supportive care and to reduce the caregiver anxiety. And taking the thorough history, like, all these points, what I've already told, and doing the proper examinations. And through the examination history, our main goal is to identify any red flag signs. If the child is having likelihood intracranial infections or something extracranial, serious bacterial infection, or, something, and of course, regarding the evaluation, whether the child require any evaluation in terms of neuroimaging, immediate CSF examination or EEG. And then we have to decide about the management, like whether the child requires any prophylactic options or not. So what are the red flag signs in the examination? If the child is having persistent irritability, reduced feeding, lethargy, complex febrile seizures, in the examination, signs of meningitis, prolonged postictal or drowsiness, evolving rash, tachycardia, which are out of proportion to the temperature, and severe respiratory distress. These are all red flags for your child, and you have to immediately admit the patient. So these are the different risk factors for getting, bacterial meningitis in apparent febrile seizures. It looks like it's febrile, but actually it is not. So if it is very young age, any history of immunocompromised child, any history of head trauma or any neurosurgical procedure like VP shunt I have done, and child is getting fever and seizures, we should be having is it the child is dealing with the shunt infection or something? We need to see. If the child is having dermal sinus or any spina bifida occulta, they can get the infection, ascending infection, and get the seizures, and they can be, mimic like a febrile seizures, but they are more of having a bacterial meningitis. If there is a complexity or any vision deficit or focal deficits, or require multiple anticonvulsants, prolonged seizures, definitely it's not febrile seizures. So in a typical child with a febrile seizures, what is the management? Is counseling and educating the parents. It's a sole treatment in children with the febrile seizures, because they are very common and having a benign form of febrile seizures. Looking at the first episode, it looks very frightening, and the parents may have feel that I can lose my child, but we have to reassure them that it appears very frightening, but actually they don't have any long-term sequelae. Your child is not going to have any neurological deficits in future. So appropriate, antifebrile, giving the antipyretics and, treating the active seizures, those are only a main point for the treating the child and the future, like now, how we are going to manage the acute episodes. So there are two settings, like the child can have in hospital for the fever only, is get admitted and got the seizures. That is a different setting. And then home, which are the most common scenario, that child is starting to have fever, which looks a little viral, and child got seizures. Like how we are going to treat those patients. So in a hospital setting, of course, ABC care, then, giving IV benzos, or either rectal diazepam or intramuscular diazepams, intramuscular midazolam, that how we can control the seizures. And of course, for the status, we need to follow the protocol to treat the status epilepticus. At home, parent should be, they should not be panic, and they have to position the child to prevent the aspiration. Like if They have to put the child in the lateral position. They have to lose the clothes. They have to see the seizures embology or do the video recording. And the one parent can, make ready the midazolam spray. These are like second seizures onwards, because first seizures, they don't know what to do. So they always rush to the hospital. But when they are just coming and we are educating that, we can give the intranasal nasal spray, and we can tell, like, according to the weight, how many spray they have to instill into the nose. And according to that, they can manage the episode. And in selected case, we can start the prophylaxis also that we are going to see. So these are the different, antipyretics and diazepam dose and midazolam dose. I'm not going to discuss over here. So antipyretic. So there is no evidence that after reducing the temperature, the child won't get the seizures. So use of antipyretic or multiple usage of antipyretic for reducing fever is not going to reduce the chance of getting seizures, because that does not going to prevent the excitogenicity of the brain. Even, cooling the child under the tap of water, different methods for reducing fever is not going to change the course of getting seizures. It just reduces the patient's discomfort, what he's getting through the fever. That is the only role of antipyretic. And they are ineffective in prevention of recurrence of even febrile seizures. This is defined by the AAP. These are the studies where they have found that they are having high prostaglandin in CSF with the febrile seizures, and antipyretics alter the prostaglandin synthesis, but they are not going to reduce the excitogenicity. So now the role of prophylaxis, whether the child require anticonvulsant medications, if required, then whether it is intermittent or continuous, daily, whether it's oral versus rectal and nasal, and whether oral clobazam versus diazepam, or whether the valproate or phenobarbital, what is required, which type of medications we should give. So if there is only one first simple febrile seizures or more even simple febrile seizures, they does not require any prophylaxis. If it's a reliable parent, we just have to educate how to treat the acute seizures. If it is prolonged, how to use the midazolam spray, and identifying the red flags only. So wait and see. That's a protocol for the simple febrile seizures. So even the administration of anticonvulsive therapy should be avoided. We have to give exhaustive information regarding febrile seizures, so they just understand why it is happening and what will be the future outcome. That will actually, it's helpful to treat the simple febrile seizures. And we just have to monitor the natural evolution. This is a class 1 evidence for, treating the simple febrile seizures. Where the prophylaxis is indicated, if it is complex febrile seizures, recurrent seizures in a day, focal seizures, prolonged seizures, or the simple febrile seizures which are very repetitive, like more than 3 episodes in 6 months or more than 4 episodes in a year. Or if the child is already have pre-existing neurological abnormality or definite perinatal risk factor, like child had neonatal hypoglycemia, child had perinatal asphyxia, some preterm intracranial hemorrhage was there. All those cases, class 2 evidence that we should get and we should start the prophylaxis. So in prophylaxis, the clobazam is preferred over diazepam because it has lesser side effects in terms of sedations and overall, activity. Clobazam is more preferred than the diazepam. So the dosage of clobazam would be around 0.7 to 1 mg per kg per day for 2 divided dosage for first initial 2 to 3 days, because there is a more chance to get the seizures in initial 2 to 3 days only. The continuous prophylaxis is not required. It is only intermittent prophylaxis. So whenever the child is getting fever, with the onset only we need to start. We have to tell the parents, like whenever the child is spiking fever, immediately you start, even in the midnight also. So don't wait for having seizure. You just start and give it for next 2 to 3 days. So continuous prophylaxis would reduce the recurrence where the valproate is preferred. But they have overall, in many a study that they have more side effects than the advantages. That's why, valproate and phenobarbital is not much preferred drug over the diazepam, over the clobazam. So here the Cochrane also says that we found no significant benefit of intermittent phenobarbital, phenytoin, valproate, or pyridoxine or even the ibuprofen, over the any intermittent diazepam or clobazam. So that's why, because the side effects are more, so we should not give the intermittent any other medications. So these are again different other guidelines given by the Japan, where we have already discussed regarding the role of EEG, role of CSF, and role of everything like antipyretic and intermittent prophylaxis. Even is there any children with the history of febrile seizures able to receive any vaccines? Definitely yes. So children with the family history of febrile seizures can receive all current available vaccines if the caregiver understands both the benefits and risk. So benefits are always higher than the risk. Very few children with the receiving vaccines, they get seizures. So it is a grade A evidence. So criteria for the admissions, when we should get the admitted to the hospital when the child is having seizures and fever. So with the simple febrile seizures, more than 18 months, admission is unnecessary. Less than 18 months, we should, daycare basis, we can just observe the child. If the child is showing any red flag, we should admit the child. So regarding the morbidities, like again, I said, like the parents always have questions, like whether my child is going to develop an intellectual disability, reducing scholastic performance, or, related any developmental going to have any concerns. So there are various, studies, what they say. So there are various studies, they say there is no difference of IQ scores on performance at the age of 7 years. The children with the febrile seizures performed as well as in the school, same as in 7-year or 11-year as per them peers only. There's no difference between 5-year-olds with the febrile seizures and 5 years without the history of febrile seizures in terms of performance as tasks. They don't have any behavioral deficits or executive functions. But if the child is having recurrent febrile seizures, they have increased risk of delayed language development. They have increased risk of ADH and Tourette syndrome. But there's no risk of SUDEP, that is sudden onset death in the epilepsy. So these are different, uncommon scenarios where the initial history would be just a seizures with fever, but they evolved into febrile status and, refractory new onset status epilepticus without underlying any risk factor, with underlying normal development. So Fires is a febrile infections related epilepsy syndrome. They have immune mediated or para-infectious etiology. There are few children, they have genetic predisposition, and it is very catastrophic chronic inflammatory conditions where the child have explosive multiple prolonged seizures, and the outcome is actually very poor for the Fires. But, we should know regarding that. So here, there is many role of EEG investigations, role of immunomodulations, and there is so many things are coming up now. All this interleukin receptor antagonist and keto diet and this, but it is very fatal, and our outcome is prognosis is very poor, long-term outcome. There are few epilepsy syndromes like genetic epilepsies. They can, initially they can mimic as a febrile seizures, but they have, prolonged seizures, like beyond 5 years also they used to get the fever and seizures. Sometimes even without fever, afebrile episodes can also occur. And other than the generalized seizures, they can have different other semiology like myoclonus, aesthetic seizures can also develop. So this is one of the condition which is called Jeff's Bliss, where the febrile seizures tend to occur beyond 6 years of age. And they are also associated with different genetic conditions like SCN1A, 1B, and GABARG1. These are different, genetic conditions like febrile status epilepticus. I've already told that if the febrile seizure is lasting more than 30 minutes, and most of them, they present with the generalized, but 1/3 of them can present with the focal seizures also. So FABSET studies that says that the febrile status rarely causes the CSF pleocytosis. Then the EEG, they say that it's mostly associated with focal slowing and attenuation. And the relationship, like, the more prolonged the seizures, they have more chances to get the hippocampal sclerosis and mesial temporal lobe epilepsy in future. So in the acute setting where the patient comes with the fever and prolonged seizures, they have done the MRI, and almost 70 to 80% of the patients, they show the abnormal signal in the hippocampus. And they followed up the child in the future. So beyond 5 years, they develop the sclerosis, and later they present with the mesial temporal lobe epilepsy and seizures. So there is a very high risk. Like if you see the MTS in adults, 60% of the patients, they'll have febrile status in the past. So there is very strong relation of febrile status with the MTS. So which is, of course, we know that it's a drug-resistant epilepsy. That's why in the initial settings only, it's very important to treat the febrile status episodes to prevent the recurrence of the seizures and prevent the long episodes of the seizures. So again, it is again related to infective as well as some kind of immune-related factors. Again, the study says the same thing. The meta-analysis said that the mesial association of mesial temporal lobe sclerosis with hippocampus sclerosis with the febrile seizures, and they have sodium channel, dysfunctions. And they also found the association with SCN1A involvement. So last few slides, vaccination-related febrile seizures. There's no different than the, febrile seizures after vaccination is same as like febrile seizures in the typical settings. So post-vaccination febrile seizures are quite rare. So maybe multiple vaccinations at a one time may increase the risk. But the current evidence says that, giving vaccinations is more useful than, the advantages are more than the side effects. So definitely we need to follow the routine schedule of vaccinations. So there's no risk of even prolonged hospitalizations. They also have very brief episodes. And there's no difference in outcome also compared to the, non-vaccinated febrile seizure and vaccinated febrile seizure. They are almost same only. So same thing what I have told. So now we will discuss this case scenarios as I've told previously. So this is case 1. So this is a 14-month-old boy with brief generalized seizures on day 1 of fever, developmentally normal, remains alert, no neurological deficits and no signs of managerial retardation. This is a typical simple febrile seizure scenario. So where what we have to do, we just have to, tell the parents that how we are going to deal with the subsequent episodes and how we are going to manage the subsequent episodes with the midazolam nasal spray. Our goal is to prevent the prolonged seizures only. The case 2 scenario, this is 30-month-old girl with a simple febrile seizures, 3 episodes in past 6 months, who presented with epilepsy in the emergency with active seizures and fever. And here the setting is uneducated parents and healthcare facilities are little, and the longer distance accessibility is very poor. In this scenario, because the child is having recurrent episodes, this is the indicator that we need to start the intermittent. We have to put the child on intermittent prophylaxis because of 2-3 reasons. One is, multiple recurrence, though it is simple. Second, the parents are very uneducated and the healthcare facilities are, it's not accessible. In this scenario, we need to put them on the intermittent prophylaxis. There's a 7-month-old girl, incompletely immunized, presented to the emergency with brief generalized seizures, along with the fever at home. Definitely we need evaluation in such children because it's partially immunized or incompletely immunized. So maybe, there is signs of infections. We feel that we need to do the CSF to rule out the CNS infections, and then only we can label them it's a complex partial seizures and treat accordingly. This is a 4th scenario. Here the 2-year-old girl with a focal seizure lasting for 12 minutes on day 1 of fever. And there is a family history of febrile seizures, no neurological deficit. What is this? It's a complex febrile seizure because it's a focal. So we just have to follow the protocol of management of complex febrile seizure. Then case 5, this is 4-year-old boy with a fever for 2 weeks with headache and vomiting. On 2nd week of fever, he developed GTCS. So this is, and on examination again, this is meningeal irritations. So in history also, there are some odd points. Though the age is 4, but the prolonged fever for 2 weeks, have some headache and vomiting. And on 2nd week of fever, he had GTCS. So usually the febrile seizures tend to occur in the initial phase of illness. As I said, the most of the patients within 24 hours of onset. Here the seizures are developing on the 2nd week. So this is very odd. And the child has already headache, vomiting, but that could be a part of systemic illness also. But in examination, again, we are finding the meningeal irritation. So we are dealing with the CNS infection. So we have to evaluate the child and treat accordingly. This is 8-year-old boy with a history of febrile seizures in past, now presented with febrile as well as afebrile with multiple seizure symbology. So this is not the typical febrile seizure scenario. This is something maybe a genetic epilepsy where the seizures are just precipitated by the febrile illness. So this is Jeff's plus, that is generalized epilepsy with febrile seizure plus. The 7th scenario, this is a 9-year-old girl with a history of complex febrile seizures in past and recurrent episode of focal motor seizures. So this is a scenario, as I said, the child had past history of complex febrile seizures and prolonged febrile seizures. So they have chance to get the mesial temporal sclerosis. So now the prototype of focal seizures are temporal lobe symbology. So this is more of like a symptomatic epilepsy. They had prefebrile seizures, but because of mesial temporal sclerosis, now they are getting the symptomatic epilepsy. So we need to treat the epilepsy as per the protocol. And if it remains refractory, we have to give options of epilepsy surgery. This is last scenario. This is a 6-year-old boy with history of fever 10 days back and came the refractory status epilepsy in the PICU and multiple AEDs. So what is this? It could be a fires. So this is a new onset epilepsy syndrome. So these are the different scenarios where, we come across with the fever and seizures. Sometimes it's very atypical. So we need to know the thorough history, how it is happening, how it is having, like what is the postictal state, whether the seizures are occurring at home and what is the duration of the seizures. So how we can check the duration of the seizures, how we can ask. We can roughly ask the parents, like when the seizures started, they were at home, that time only the seizures subsided, or while transitions, like while reaching to the hospital, the seizures subsided, or after reaching to the hospital while after receiving the anticonvulsant only the seizures subsided. So that can give you a rough estimate regarding the duration. If it is after reaching to the hospital, definitely it's a prolonged episode. So thank you. I'm just ending my presentation, and I'll be happy to accept the questions the audience is having.
Yeah.
Sorry, my daughter is disturbing in the background. I think she's coming and she was just asking, like, I want to go with the mother.
Excellent presentation, Smriti.
Thank you, sir.
Covered vast topic. I have only 2 questions to ask you. What
Yes,
about
sir.
intermittent prophylaxis? What you advise? And do we have a literature for parents
Yes, sir.
in simple language about febrile seizures?
Yes, sir. So, yeah, sir. So the first question, the intermittent prophylaxis. So whenever a patient comes to me for the first time, it's a very typical scenario that around 1.5 years of age, the child is getting fever and seizures within 24 hours. There is no other deficits. It was very brief episode. Definitely, it's a simple febrile seizures. Now, to get the recurrence is almost like 1/3 of patients only get the recurrence in future. So I know that it could be a first or last seizure of his life scenario. So maybe I will just tell them that we will just see like how it is naturally evaluating. We can wait to start the intermittent prophylaxis, and I can give the informations regarding the how to prevent the prolonged seizures in the again scenario. So I just tell them, this is very common scenario that up to 5 years of age, your child is, chance that the child is able to get the seizures. Definitely we need to see in total, like, is there any other risk factor to get the recurrent seizures, like family history, and, within like peak of temperature is very low and the child got seizures. With the onset of fever, only child got seizures. So those are the risk factor where there is a chance that the child can get the seizures. So there are 2 settings. If the patient's high the risk factor, if the parents are very anxious, if they are coming from the remote place, I will put on them on an intermittent prophylaxis. But if they are coming to from the city only, there are no risk factors, educated parents, I know that the parents are able to manage the subsequent episode, I will not put them on prophylaxis because I want to check the natural evolution. So, and of course, I used to give them a midazolam spray, positioning and all. And I used to give them a natural in Gujarati language or whatever Hindi language literature, saying that what are the things they have to do during the active seizures, written things I used to give them. Like, and of course, like how many spray they have to instill. So everyone in the family should be educated regarding to prevent the seizures. Our main aim to prevent the prolonged seizure, because that only is going to damage your child's brain. Otherwise, short, brief episodes are not going to change any, it's not going to harm your brain. And second, aspirations, that is the main thing we need to prevent. So positioning, lateral position, loosening the clothes, and checking for the tongue bite, and all those things are very important to treat the acute scenarios. Yes, sir.
Okay. Second thing, whether we have a literature for parents, printed literature.
Printed literature, yeah. So printed literature, like it is not like dictum, but we used to give, sir, printed literature for the febrile seizures, like in any types of seizures. It's not like febrile, but yeah, we should prepare and give, like how to check the temperature. And when you have to, like, even sometimes what happens, they just starts giving antipyretic, but they don't give the clobazam. They feel that once the seizure starts, then only we need to give, but it is not like that. Whenever the fever is spiking, immediately we need to start the frisium, so that clobazam, so that the chance to get the excitogenicity of the brain can be prevented.
Okay. Are there any questions? I don't think there are any questions. So thank you very much. It was excellent. Dakshaben, will you like to make any comment? You are mute, Dakshaben. No.
Dakshaben, you are muted. Can you please unmute?
Oh, sorry. I think she covered everything so nicely and in details. I don't think I have any query or questions.
Okay.
Thank you, ma'am.
Okay. Dr. Chitra, you have any comments?
I would just like to say that, Dr. Smruti, your presentation was very insightful, very informative. And actually, while seeing your presentation, my husband, who is currently a pediatric resident, he was also like just discussing the slides and the protocols that you were talking about. So thank you so much for a very informative session. And
thank you, Dr.
if there are no further questions, we can conclude this session.
Yeah.
Okay. Okay. Thank you.
Thank you.